please describe what you see in this video?
Yes, in the video, I can see a 3 years old child in uh, lying position. Um, is probably in the hospital settings with audible wheeze. He has cough and tachypnea. I want to count the respiratory rate and respiratory distress in the form of chest indrawing and intercostal recession. And there is no dysmorphic phase, and I could find any kind of device attached here.
So, what is your own top diagnosis and
Top
differential diagnosis?
diagnosis is a case of with audible wheeze. So my provisional diagnosis from the video is acute asthma, and differential diagnosis it can be pneumonia, heart failure, uh, then
Others?
foreign body, and any kind of aspiration, and yes.
Or anything? Bronchiolitis? Do you want to
Yes,
keep?
yes, as the child is 3 years, so but viral multi-trigger as it is 3 years old, for this reason I'm not considering in this moment.
Okay. Then it is also viral induced wheeze,
Okay, okay,
bronchial asthma, early onset. It can be multiple trigger wheeze, secondary wheeze due to chronic chest conditions like cystic fibrosis, immunodeficiency, anatomical malformations, bronchiectasis, bronchiolitis obliterans. Bronchiolitis obliterans is common 3 years of age.
okay, yes, 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 yes. Bronchiolitis obliterans can come, yes.
Actually, it is a case of bronchiolitis. Suppose it is a 2 years
Okay,
age old child.
okay.
So, okay, so did you tell that? So, what is the most common organism causes bronchiolitis?
Respiratory syncytial virus
And the age is
and
6 months to
adeno.
2 years.
Yes, yes.
And what the history we ask?
Onset course and duration, and the feeding history, and p history, how much amount of the p, and then is there any kind of convulsion, cyanosis, and is it is the first attack or repeated episode, and birth history is important, antenatal, natal, and the postnatal history, and how this improve, aggravating factor and the relieving factor,
Okay.
and passive
So,
smoking in the home.
okay. So history we ask the onset course in duration, what increase, what decrease. Is it first time occur or recurrent occur? Fever, weight, activity, sleep. Any cyanosis or pallor, choking, drooling, missing any toy. Okay, ingestion of foreign body we can keeping. So missing any toy, any apnea, vomiting or aspirations, family history of atopy. Vaccination history is very important. Vaccination history, exposure to COVID patient or parents received COVID vaccine. Parental history is very important. Prematurity, perinatal any screening. What examination we do in this patient?
Yes, I will do the general examination, including mostly emphasis on the vital sign, and including the SpO2 and hydration status, and
Hmm.
respiratory system examination and cardiovascular system examination to exclude the differential diagnosis, and abdominal examination, liver may be pushed down here.
Okay, yeah. You're right. We are doing the ABC air breathing circulation, especially the hydration status, vital signs, capillary refill time, oxygen saturations, head nodding present or not, chest examinations. In chest examination, what we find? Widespread fine crackles, wheeze, respiratory distress, subcostal and intercostal retraction, hyperinflated chest. And abdomen, you can tell that sometimes heart failure develop, so we can do, and cardiac because of differential diagnosis. Okay. So, what investigation will you do for bronchiolitis?
Bronchiolitis is a clinical investigation, a clinical diagnosis. But if the child has any localizing sign or cardiac murmur or atypical presentation more than 18 months, so we can suggest the chest X-ray. Urea electrolytes, if we keep the patient nothing by mouth, and yes, SpO2 monitoring. And capillary blood gas is the respiratory rate is more than 80, and if fever is more than 39 degrees centigrade, then blood culture with the discussion of the consultant. And if there is prevalence of respiratory infection of the by respiratory syncytial virus, for viral swab for respiratory syncytial virus.
Yeah, you tell it very nicely. Investigation, it is a clinical diagnosis except in certain conditions like SpO2 in room air, capillary blood gas if respiratory rate is more than 80 breaths per minute, and avoid tests do not contribute to immediate management. So perform following specific indications like viral nose swab for respiratory virus PCR, chest X-ray we can do because age is more than 18 months, and cardiac murmur or atypical any presentations if urea and electrolyte we do, and blood cultures if there is sepsis or temperature high grade. And what is the management we give?
We give immediate management, and immediate management, we will admit patient under the cubicle with strict hand hygiene, and we can give the suction by normal saline and nursing in propped up position, and supportive measures for airway breathing and circulation. For breathing oxygen, if the saturation is less than or equal to 90%, then we will prescribe oxygen inhalation. If it is not improved, then we can suggest high flow head box, or if not improved, then high flow oxygen, not if not improved, then CPAP. And then this is for breathing. And for circulation, if the patient respiratory rate is more than 80, so we can keep the patient nothing by mouth. Otherwise, if the respiratory rate is less than 80, and then we can give the NG2 feeding. And then after feeding, uh,
Yeah.
yes, this is the
So
feeding.
management first in history we tell that I will take the full history. Then airway, breathing and circulation, dehydration status, oxygen we give, admission if needed after involving my senior and consultant. Nurse in cubicle with head up to avoid the splinting of the diaphragm and clear airway with careful suctions. And respiratory support we give oxygen if saturations less than or equal 92 or 90%, both they mention. And if impending respiratory failure, then humidified high flow nasal cannula oxygen. If not or working, then we go the CPAP. And circulation and hydration status, assess the circulation to treat shock, correct the dehydration if present, give IV fluid. Normal saline we are giving, restriction to 80%, and sodium chloride 0.9% in glucose. And feeding is normal feeds if tolerated, otherwise we give NG tube feed if oral intake is insufficient. And IV fluid, when we give IV fluid in bronchiolitis patient?
We give IV fluid if there is a significant respiratory distress, and the NG2 feeding is not tolerated. Then for the risks of CR, we can give the 20% cartel of the total requirement of the fluid.
Yeah, IV fluid we give if respiratory rate is more than 80, persistent vomiting, oxygen saturation less than 92 on supplemental oxygen, deterioration of the respiration while giving NG tube, respiratory distress with poor coordination between suckling, swallowing, and breathing. If we give antibiotic or not in bronchiolitis?
In case of bronchiolitis, usually we don't give the antibiotic, but if the child is less than or equal to 6 weeks, so discuss with consultant regarding antibiotic.
Yes. Antibiotic after consultation. If
Yes.
baby age is less than 6 week or patient with temperature more than 39 degree. And antiviral oseltamivir if symptom less than 48 hour and influenza test is positive. Okay, it's not needed. Criteria for admission. What are the criteria for admission bronchiolitis patient?
Absolute criteria are the apnea. There is
Mhm.
diagnostic diagnostic is not clear. There is dehydration, inadequate feeding,
Mm. And
and
relative?
and the SpO2 less than 92%.
And relative?
Relative is there is coexisting cardiac disease, and if the age is less than 6 weeks.
So the criteria of admission of bronchiolitis are absolute and relative. Absolute are apnea, any underlying cardiac conditions, saturations less than 92% in room air, inadequate feeding, dehydrations, and diagnostic uncertainty. Relative are reattending, age less than 6 weeks, difficult family circumstances that family actually not take the ability, pre-existing any lung disease and any chronic disease like neurodegenerative. What are the discharge and follow-up of bronchiolitis patient?
Discharge when the feeding is when the child is feeding is orally, feeding is tolerated, and SpO2 is more than 92%. And we follow up usually in case if it is needed, in case of ventilation is needed or there is consolidation, so hospital follow up, otherwise all the cases GP follow up.
Yes, very nicely you tell. Discharge we home when feeding fully orally or saturation more than 90% in air. And hospital follow-up if patient ventilated on PICU, consolidation in chest X-ray or premature baby with chronic lung disease. Then hospital follow-up. Or otherwise GP follow-up. What is bronchiolitis obliterans?
Bronchiolitis obliterans is a serious and severe complication following the bronchiolitis. It is usually occurred following the adenovirus infection, adenovirus bronchiolitis, and here the airway is totally obliterated, and the treatment option is continuous steroid nebulization.
Okay. I want to ask the one thing, bronchiolitis obliterans comes on the history. So what are the feature support in history that it is a diagnosis bronchiolitis obliterans?
Yes, bronchiolitis obliterans presents with the history of chronic cough and not growing well, and if there is increasing, there is aggravating factor is any seasonal variation it can comes, and there is a past history of hospitalization, and there is repeated respiratory tract infection, and
Okay.
yes.
And there is no any hepatomegaly, splenomegaly, anemia like leukemia. It is not. Though here repeated admitted the child with fever, right? Because leukemia sometimes they confuse with that bronchiolitis obliterans history. They tell that is it leukemia, is it leukemia or not? Because child is again admitting. So bronchiolitis obliterans treatment is steroid and nebulizations.
Yes.
Okay. So this is all about bronchiolitis. Thank you very much.